So our job here this afternoon is to talk briefly about hypoparathyroidism. When the surgeon does the job right, it's not an issue. The problem is, as we know, occasionally things happen and either more glands are removed than should have been, or sometimes it's necessary to remove all glands, and because of that, typically in the thyroid cancer or head or neck cancer situation, patients are going to have hypoparathyroidism. So in the next 20 minutes or so, I hope to briefly describe some characteristics and the differential diagnosis of hypoparathyroid disorders, realizing that 3/4 roughly of the patients that we'll see are post-surgical. The problem is in the office when you examine the patient or you're talking to the patient initially, if they do not have a neck scar present, you know that you're in a more difficult situation that's going to take more time to figure out. So it's usually pretty evident if they're post-surgical or not. We want to talk about some of the laboratory and imaging techniques that are useful in sorting these things out, and then we'll talk about some of the medical management options that have developed over the last 5 to 7 years with various studies. So just briefly, when these patients present, we typically expect to hear about symptoms related to low calcium in the blood. Cardiac manifestations are a fairly common pickup when these are done. Now, many times in our clinics, we're not checking electrocardiograms very often, but these show up because they came through the emergency department, or sometimes our cardiology colleagues will see them. And this shows a case of a patient that Michael Manstadt at Harvard in Boston showed one of his patients in terms of the change in the QT interval that developed when the patient initially presented with a serum calcium of 7.3 milligram per deciliter on the top panel, and then subsequently with the calcium, when it was normalized to 9.2, you can see that the QT interval, whether it's corrected or even baseline, did shorten as expected. Michelle Rubin at Columbia in New York has shown from biopsies from iliac crest sources about changes in the architecture that occurs in patients who have chronic hypoparathyroidism. The panel on the left shows the patient who has hypoparathyroidism. The panel on the right is the healthy control. And so when you look at these, if you didn't know if this was a board exam question and they said, what's going on here, you and I would probably pick the panel on the left as being the one that we think is normal, and the one on the right might have osteoporosis or some other bone disease. But this condition, because parathyroid hormone is missing, bone turnover is reduced, bone mineral accumulates, and the skeleton becomes more heavy and dense, as shown on the left. Bone turnover markers and bone density are affected as you might expect. In general, bone turnover markers are uniformly decreased, whether it's formation markers or resorption markers, and they're proportionately decreased so that the Z-scores in these patients are roughly 1 to 2 standard deviations below the age-adjusted healthy controls. If you look at bone density is increased as you note, but it's not increased by 6 or 7 standard deviations. It's only increased by about 1 to 2 standard deviations. Lumbar spine typically increases more than total hip, femoral neck, or distal radius. But that just gives you representation from various studies. Some of these patients do have other phenotypic features that if we're not looking for them, we could miss them. So dental enamel hyperplasia is fairly common, especially in those who have a inherited or congenital form. Not yet clear what they have necessarily, but this is very common. Cataracts are very common as well, and typically it's said by our ophthalmologists that a posterior subcapsular cataract is the most common presentation in these patients. They can get, if they're older, of course, they can have other age-related cataract presentation at the same time. But in the many of the inherited forms, familial forms, these people develop cataracts at a much earlier age that require surgery. Basal ganglia calcifications, you can see the spectrum of punctate on the left to much more diffuse intracerebral calcification. And there's a number of studies reported from India that describe this in great detail. But this is the spectrum, and typically many of our patients are picked up with chronic hypoparathyroidism on a CT scan or MRI scan that was done for other reasons, and lo and behold, they have basal ganglia calcification, and it's not Farr syndrome or something else explaining it. It turns out they've got hypoparathyroidism, which is relatively mildly symptomatic. So turning from the phenotypic features, one of the things that we're faced with in the office is what is the differential? As we said earlier, if it's post-surgical, it's usually very clear and evident. Most of them can time the day after surgery at which they first became hypopara, because they became fairly symptomatic, oftentimes before they left the hospital, sometimes occasionally just after they left the hospital. They got discharged the one day, and a day later they're back in tetany because of the timing of the onset of the hypoparathyroidism. But as endocrinologists, we have to think about all the other possibilities, and certainly autoimmune hypoparathyroidism is fairly common, oftentimes in association with other autoimmune disease. That's the only tip-off that we would have. One of the issues with this right now is there's not a specific pathognomonic antibody identified yet that is able to make this diagnosis. There's a lot of work going on in this area. The problem is, I hear from colleagues in Stockholm that there's about 20 or so different antibodies they have identified in their autoimmune population. And so it's going to be very difficult, I think, to have a single antibody or even a panel of antibodies that may answer this question. Iron overload is rare, so is copper overload, but these in the right setting clinically with thalassemia, that can happen. Hemochromatosis, occasionally, this is maybe more common in our setting, but whatever setting you are, you have to think about both iron and copper overload. Metastatic disease is always an issue. If 90% or more of the parathyroid gland tissue is removed or damaged because of the metastatic disease through infiltration of the glands and taking over the glands, you can see hypoparathyroidism there. There's rare cases of radioactive iodine therapy with Graves' disease or sometimes thyroid cancers that later on develop hypoparathyroidism. There's other cases of external beam radiation therapy for head or neck cancers that have been reported to cause it. And then one of the other issues that comes up is magnesium is a very common contributor to this, in the sense that if it's either low or high, it will cause a physiologic hypoparathyroidism. If you don't check magnesium the first time you evaluate a patient who you suspect has got hypoparathyroidism based on the biochemistries, you can miss magnesium deficiency or excess as a cause for this. And between the two, of course, the deficiency is the more common scenario. Excess rarely will occur except with tocolytic therapy in this day and age during labor and delivery. If all of these are ruled out, then you're still stuck with maybe 9 or 10% of patients who seem to have a familial inherited form but no obvious cause for genetic disorders. And this is where newer studies are expanding the different mutations that are known to cause this, and there's a number of papers in the recent literature that talk about this and the differential for those. In terms of the overall picture, prevalence, incidence, and mortality, we're still gaining information on this. Until about 2009 or 10, there was no data published in the world about either incidence or prevalence of the disorder. We did a study in our own institution, Olmsted County, where we found a prevalence of 37 per 100,000. Other studies followed. You can see that most of these are in the same range. There are a number, though, that are less. The Norwegian study by Dr. Astor showed that their figures there were maybe a third of what we had found and what the Italians and the Danes had found. So there is a spectrum. The Tayside, Scotland studies, on the other hand, using a different method for assessing hypercalcemia and deciding who had hypopara or didn't, found a slightly higher prevalence. So the truth probably is somewhere in the middle, and your particular situation in your country may be different. And these are studies that need to be done as time and resources develop to do them. For incidence, it's interesting because Denmark has got a published study, so does India. They're in the same ballpark range, not very high, of course, and quite a bit less than what the overall prevalence is. So this kind of fits with our clinical experience, but those are the only two papers published right now, to my knowledge, in the world on the incidence of hypoparathyroidism. Now, mortality, you might anticipate with low serum calcium, cardiac rhythm disturbances, many of the other things that these patients experience, and certainly based on symptomatic complaints, you might anticipate there would be some increase in mortality. But the data so far doesn't really show that in a convincing fashion. The Danish studies are the best done. They show really little variance in there with certainly overlap of 1 in terms of the confidence intervals, and so it's not possible to say that there's an increased risk. There's a recent paper that showed a slightly increased risk, but again, I think the Danish studies are still the best we have, and that's where most of us would focus. So what about risk of complications? The Danes have published in their experience both on post-surgical and non-surgical hypoparathyroidism, And what you see is that the risk of hospitalization for complications, is what you'd expect. Certain things like, for example, seizures are markedly increased. Cataracts are increased if you have the non-surgical form. Upper extremity fractures, they found, was increased in the non-surgicals but decreased in the post-surgicals, which is still a conundrum that we do not have an answer to yet, and it's not clear whether there really is an increased risk of fracture or protection from fracture just because you have high bone density and reduced bone turnover. It would make sense if that was the case, but it's not yet convincing. You can see that intracranial calcifications are common for both renal effects, ischemic heart disease, increase in non-surgicals but not post-surgicals, and neuropsychiatric disturbances, of course, more in the non-surgicals. So this is our best data for how often these complications develop and where they have come from. We need more studies in this area as well because it's hard to do large studies unless you've got a countrywide database like they do in Denmark. In terms of management of this, a number of guidelines have come out. The European guidelines were first in August of 2015, followed by these guidelines published in the JCNM. Maria Luisa Brandi at the University of Florence led the effort on this. And so you see that we've got these various guidelines that are fairly close in terms of the recommendations. There's also what's called a clinical disease state clinical review by the ACE organization in the US that really isn't a guideline, but it encompasses a lot of the data that's behind the guidelines. And so with this, everybody agrees that the target for therapy should be low normal serum calcium, high normal serum phosphorus, 24-hour urine calcium less than 7.5 millimole, or in most cases less than 400 milligrams, and then calcium phosphate product at least under 55 with some variation about those numbers. So the issue is we don't have good prospective long-term data. Much of this is expert opinion based on personal clinical experience. In terms of management, what's typically done with conventional management is relatively high-dose calcium supplementation, active vitamin D supplementation, calcitriol or alpha-calcidol if you have that. Most of us would feel that regular vitamin D2 or D3 should also be a consideration because some tissues in the body cannot respond to calcitriol or alpha-calcidol. They have to form it within the tissue, and if your D2 or D3 reservoir is low, you're going to run into some problems at local levels. Thiazide-type diuretics and low-salt diet are necessary in managing the hypercalciuria that develops not usually before therapy is started, but when patients are started on calcium and calcitriol, typically, a number of these patients will develop hypercalciuria, subsequently getting kidney stones as a consequence. And then if the phosphate levels are high, we can use phosphate binders, we can try a low-phosphate diet if necessary to control this. But I'll tell you, in my own experience, and I'm sure you face these patients also, even if you do everything right, sometimes the phosphorus will not come down to the level that you want, and the calcium phosphate product is over 55. You really have nothing else you can do at this point up until relatively recently when new medication became available. So the European Society guidelines by Jens Ballerslev, the University of Norway, published what they recommend for their guidelines, and these are similar to what we've just gone through. The key points are that serum calcium does not need to be in the normal range for healthy adults. In the lower half of the reference range without hypocalcemia is the goal. For most people, that would be a serum calcium somewhere between 8.0 and 9.0 milligram per deciliter. Some patients do well at that. Some patients are very symptomatic at that level, and they require a higher calcium level. But that's the target that we usually will shoot for. Serum phosphorus ideally will be within the reference range, the calcium phosphate product within the reference range. Serum magnesium must be checked and found to be normal because if it's too high or too low, that's an issue. And then urine calcium, the goal is to try to maintain the level obtained within the reference range for gender, realizing that men have more urine calcium than women, and there's a slight variation in that range because of that. Adequate vitamin D is targeted, and then the last point can't be overemphasized because the focus is really on long-term well-being and quality of life. Most of these patients who are able to achieve biochemical goals feel better, sometimes not completely better, and then the question is, well, if they're still having quality of life issues despite what looks to be adequate biochemical control, further manipulation of the supplements that you give and other things that you can do don't really change things, then you're still sort of left with a subset of the population that still isn't happy because they don't feel well, despite the fact that you're telling them your biochemistries are great and you don't have to change things. So this slide comes from the JCNM publications in 2016 saying, when is it reasonable to consider more than conventional therapy? In this case, we have adjunctive therapy that's been approved in the US, and EMA has approved this in Europe as well. This is coming to the rest of the world eventually, but because the drug is expensive, it's going to take a time, and it may not be possible in some countries to have this anytime soon. So because of this, we might even say the same considerations could be given to teriparatide, because even though that's off-label, it's not approved for this. For some countries, this is the only option that you have for treating beyond conventional therapy, and I think it's a very reasonable consideration if you make that choice to do that, because you have no other choice essentially at this point. So the reasons that we would think about this would be inadequate control of serum calcium despite best efforts. Best efforts means in this case that in the hands of an expert endocrinologist or somebody who's very focused on this has tried to get these things under control within a period of 3 to 6 months. If you're not able to achieve it by 3 to 6 months, the odds are they're going to need something more than conventional therapy. Oral calcium and vitamin D medications may be required to control the serum calcium or symptoms if they exceed 2.5 grams of calcium a day or more than 1.5 micrograms of activated vitamin D per day. That's a threshold at which most of us say, well, it's reasonable to consider another therapy. If you have development of hypercalciuria, kidney stones, nephrocalcinosis, stone risk, or a reduced renal clearance because of the effects of the hypercalcemia, that's also a reasonable consideration. And then hyperphosphatemia or calcium phosphate product above certain thresholds, that's a reasonable consideration as well. If you have GI tract disorders associated with malabsorption, such as celiac disease, bariatric surgery, or other, that's a very difficult situation to control conventionally. And then finally, the reduced quality of life is the last point. I'm going to show you some recent data from the extension of the REPLACE study that got this initially approved, and I'm just going to go through this fairly quickly because of time. I'll point out not the details of the study, but it was possible to give different doses, 4 different doses actually, of the recombinant human PTH1 to 84. This shows the change in oral calcium and calcitriol supplementation during the 72 months of extension study. Calcium requirements actually increased a little bit, whereas vitamin D requirements didn't change much during the course of that 5-year follow-up. Albumin-corrected serum calcium was maintained in the range desired. And then a very important slide showing that over time urine calcium did decrease, where at the beginning in the first 6 months of the clinical trial it didn't. And so the feeling is this is something that just takes a while to fully process the calcium that's been built up in the skeleton prior to beginning therapy to where the urine calcium eventually will decrease. And so we can talk more about that later. Now, in my last 2 slides, I want to emphasize several things. Besides PTH1 to 84, there's a lot of activity in this field. Pharma, not big pharma necessarily, but pharma is looking at this in terms of various options. And so I've summarized here everything that I know about that has been tried or being thought about. The top 2, Natpara is the brand name, of course, of PTH1 to 84, Natpar in Europe and elsewhere. Teriparatide, we still have that. These have been given by pump infusion methods, mostly by Karen Weiner at the NIH, so that's an option. Eric Erickson in Norway has done the same thing. They've tried implantable microchips. They've tried other PTH analogs. There's a small molecule PTH1 receptor agonist that's being developed, 2 different molecules, but one that's coming to clinical trials. Calcilytic therapy has been considered, microencapsulation of parathyroid cells, stem cell therapy, and finally parathyroid gland transplantation are all on the table as options. And I think in the next 5 to 10 years, there'll be a lot more studies showing which one of these works best and what can be done. So my last slide here basically is to say, well, what about our colleagues at surgery who do the best they can? They're all well-intentioned, but sometimes bad things happen. How do we reduce the risk of them taking out more or leaving devascularized glands that are not going to function eventually? And there's actually a number of methods being developed, most of which are used intraoperatively to visualize the gland to make sure that at least one gland with good vascular flow is left. And there's a number of proprietary devices, 2 of which have been approved in the US in the last 8 to 10 months. Others are being developed elsewhere. I'll leave you with a summary slide that talks about just the overview of this. This is a rare condition, essentially. surgical in most cases, 75% or so, but a wide range of other differential diagnoses and genetic causes are also in that picture, harder to diagnose now because we don't have these tests clinically widely available. The treatment usually includes conventional therapy, but now we have the adjunctive therapy of PTH-184 or possibly teriparatide in your situation. I'll leave it at that and maybe answer questions later.